There you go.
Good morning. This is February the 3rd, 2026. The time is 10:35. I'm Chairman Sabida Kumar. I call the Insurance Committee of the Tennessee House of Representatives of the 114th General Assembly in order, or to order. Members, please enter the meeting and register. And clerk, please open the roll call. Clerk, please count the members present.
Mr. Chairman, you have 17 members present. You have a quorum.
Thank you. We have two items on the agenda. In the interest of time, we are going to take the presentations first. These presentations are about the use of technology in insurance claims process. We have representatives from Blue Cross as well as the TMA. Will the gentleman from Blue Cross, Mr. Marty and Mr. Sobel, please come on up? Oh. We are out of session for the presentation. Kindly go ahead and introduce yourself for the record and tell us what you want to tell us.
Thank you. Good morning, Chairman Kumar and members of the committee. I'm Russell Marty, Vice President of State Government Relations for Blue Cross Blue Shield of Tennessee. With me today is Dr. J.B. Sobel, Blue Cross's Vice President of Enterprise Risk Adjustment, Quality, and Affordability. We appreciate the committee giving us the opportunity to speak about the use of technology in health insurance claims processing and Blue Cross's efforts to promote affordability and medical claims integrity. It's a subject that this committee will take up this year with legislation, and it's an important issue for healthcare providers, patients, and health insurance premium payers. Dr. Sobel is a subject matter expert for a recent claims payment integrity initiative that Blue Cross began in April of last year, which is the topic today. So I'm going to turn it over to him for the majority of the presentation. But before I do, it's important to speak broadly about why Blue Cross implemented this initiative. Our mission is to improve the health of Tennesseans and respond to growing demands for affordable health care. Based on our most recent data, 2024 marked the second consecutive year that we saw record claims costs. In 2023, we paid $17.8 billion in claims. We paid $20.1 billion in claims in 2024. That's an almost 12% increase year over year, despite a 2.5% drop in membership. Claims have risen 25% in the past 5 years, so we owe it to Tennessee employers and our premium payers to find ways to control costs. One of those being our claims integrity initiative, which Dr. Sobel will discuss in greater detail. Another point I'd like to emphasize is there are some misconceptions about if Blue Cross is using artificial intelligence to make adjustments to claims. Very simply, the answer is no. Our process follows industry best practices and evaluates provider claims data to identify outliers who have a high percentage of high complexity coding levels. Those outlier provider claims are then evaluated by nurse reviewers, human clinicians, to verify if the high complexity codes are supported by clinical evidence. Any adjustments to claims are made by these nurse reviewers, not AI, not an algorithm, not any kind of computer software. I'll now turn it over to Dr. Sobel to talk about our process and the issue we're responding to in greater detail.
Good morning, everyone. In addition, for my introduction, I just wanted to also mention that I'm a board-certified Tennessee licensed emergency physician. I reside in Chattanooga, so I understand a little bit about the landscape on both sides of this discussion. But I wanted to take the opportunity to share with you, I'm going to advance our slides, a little bit about technology in healthcare, and in particular, the use of artificial intelligence that is embedded in electronic medical record software and what it seems to be doing in claims that we've been receiving at Blue Cross Blue Shield of Tennessee. The tools that exist are embedded in the software. So this is not to say that providers are trying to do something with those tools. It exists as part of the natural flow of documentation and trying to adapt to better coding practices. But what this technology also does is takes information out of context. So it looks for keywords and information, interprets them, and then can assert that as a diagnosis without justification always behind it. There's a new phenomenon called ambient listening that's been introduced by some of these software companies. And in that, it actually records the encounter between a patient and their doctor. It looks for keywords in the conversation and makes diagnosis suggestions. And at the end of the visit, the record, the audio file is deleted. So there's no record of what it captured and what it was based on other than the information it has flagged, which makes auditing very difficult. It will prompt providers to add documentation where they feel it's lacking to try to support certain types of diagnoses, influence claim submissions where it will suggest diagnoses to a coder to be able to add to a claim, and look for patterns of high-risk denials where certain services seem to be getting denied by a provider and add information to try to substantiate it. And again, if that's part of appropriate documentation, that's all appropriate for our standpoint as well. What's happening, though, is this contextual application of artificial intelligence is causing a creep to higher intensity services, diagnoses, and as we'll discuss in patient-doctor office visits, evaluation and management coding. The other part of this technology is that it's created the ability with simply one button, one touch, you can generate a full denial request to the payer. It will pull the clinical record together. It will search the internet and try to get substantiating documentation, and it will actually submit it to the payer. And we're not using artificial intelligence, but this is overwhelming our ability right now to be able to timely process provider reconsideration requests, sort through them, and get an appropriate answer to the provider. I'm going to give you 3 examples this morning. The first example is a facility-based example. So this is from hospital billing that we see. And in this example, this particular scenario is focused on newborn deliveries and a condition that's called acute post-hemorrhagic anemia. Anemia is a low blood count that happens after delivery. As I'm sure we're all aware, when women give birth, there is a blood loss that's expected. When it becomes severe, the diagnosis of APA or acute post-hemorrhagic anemia is warranted. The issue is, if you look at the graph on the screen, you'll see the blue line representing the frequency we've received this diagnosis on claims over the time period from 2021 through the beginning of 2025. And the treatment for this condition, this very severe form of anemia, is a blood transfusion. And the red line indicates the frequency with which blood transfusions are being ordered and performed. So a diagnosis is driven based on the belief that there will be a certain treatment behind that diagnosis. And when you don't see that treatment, it creates a phenomenon called discordant treatment. So we expect to see something that we don't, but the diagnosis is still generating an increased claims expense. We'll go ahead to another example that is also facility-based around a condition called sepsis. So this is a life-threatening bacterial infection that exists. And in the information I'm going to share with you, we removed all of the COVID-19 artifact, meaning all of those claims were removed because it would be correct to assume, well, COVID-19 would skew this. And what we saw is the diagnosis of this severe, overwhelming infection rose by 7%, again, excluding COVID. But the length of stay for patients with this diagnosis dropped. There have been no significant changes in treatment for this condition. And you'll see that part of the reason that there's a reduction in length of stay is due to treatment not aligning with the diagnosis. If you look here at the top right on the graph, this shows the percentage of sepsis diagnoses we've received on claims as a proportion of the total infectious disease diagnoses that we receive. So there are a variety of different diagnoses that can be submitted. Pneumonia, urinary tract infection all go into that category. Sepsis is consistently increasing. Again, no COVID-19 data in there. And if you look at the bottom, what you'll see is that there's 3 cohorts we've identified by looking through medical records. One is the type of patient who very likely has sepsis, received supportive treatment, received antibiotics for the treatment of sepsis. So that's the red line across the bottom. The yellow line represents people who have received some level of supportive treatment and have had no antibiotics, which usually represents a viral infection. And then more concerningly, the blue line, which has jumped up in the 3 time periods, are people who have been diagnosed with sepsis, but have had no treatment for sepsis in the medical record, have had no antibiotics, but are still being diagnosed with sepsis. And the belief is at the beginning of the patient visit, the physician is ruling out certain conditions, among them being sepsis, and that shows up then on a claim as one of the diagnoses, even though it didn't actually exist. It was ruled out. But you can see that it's having an impact, which generates an increased cost pressure on those facility claims. I'd like to switch gears for the final example I have for you, and this is focused on outpatient provider office visits, and there are codes that are used in a category called evaluation and management, or E&M codes. The E&M codes were created by the American Medical Association, not by Blue Cross or any other insurer. They are endorsed by all of the American Medical Associations. CMS uses them to generate pricing, and we use them to process claims, as does every insurer. In the configuration for the evaluation and management codes, there's 5 levels. 1 is the least intense services, 5 is the most intense services. And in 1992, when the American Medical Association first came up with this configuration, they saw it as a bell-shaped curve. So the majority of patients would be in the level 3 category, the middle of the road. What's happening in the data, and I'll show you in a moment, is that there's a skewing over to the higher intensity services, level 4 and 5. And again, this is being substantiated through these electronic medical record systems by over documenting the information that's needed for the visit based on what the chief complaint is. So in this example, this is actually a Tennessee provider group, a large provider group that is in our network. And these are claims from 2017 through 2025. And what I want you to notice in particular, let me see if I can point to it, is where the arrow is, see how the drop is occurring. So the green line at the bottom represents the level 1 through 3 levels. Those are the medium and low intensity. The level 4 diagnoses are in the blue, and the level 5, E&Ms are in the orange. You can see when we instituted some audits on certain provider claims, there was a drop in 2019 of the level 4 and 5s, but the level 3s remained the same. And then if you skip over to 2022, you'll notice a rapid increase in level 4 and 5 billing from this same provider. And that was through the introduction of a new billing system that had AI technology embedded in it. So even though we're auditing, they're documenting it at a far faster rate. And the system is what's creating the overcoding information in the record. And the diagnosis is not corresponding with that. So what happens is not only does it increase costs, but it forced us to say, how can we manage this increasing expense? So please keep in mind in our commercial business segment, 70% of those that we insure are what are called self-insured clients, similar to the state of Tennessee Employee Health Plan. That means we provide the back office work, we provide a network of providers, but the employer pays the claims. So these claims are being absorbed by employers. And if you have certain plan designs like a high deductible insurance plan, until you hit your deductible as a member, you're paying these costs yourself. So we implemented in the middle of April an edit through a vendor, which is a national vendor named Cotiviti, and is used by multiple other insurers to look at outlier providers. And outlier providers were identified by providers who submit more than 50% of the claims to us as level 4 or 5, the most intense coding. Once they were identified, then we looked at claims that were submitted by these providers, and we look at the diagnosis with the level that they've coded. And the vendor has a crosswalk algorithm, no artificial intelligence. It's literally, this diagnosis is not expected to usually result in that high intensity E&M code. And a clinician reviews the record and makes a recommendation whether to change the intensity level down one level or to leave the claim alone. And so that's the edit that we put in place. And when you hear down coding, this is what they're referring to. The goal of the program is not to reduce codes. The goal of the program is to pay appropriate amounts for the services that are rendered. In this, providers have an appeal right, and I'll show you some statistics on this. But we look at all of the appeals, and if people are presenting claims that are meeting the criteria, we remove on a monthly basis providers that no longer appear to be outliers based on the criteria I explained. And the average impact across all our lines of business is $31 per claim. So when you move from a level 5 to a level 4, it's a little bit bigger difference. From a 4 to a 3, it's a smaller difference, but on average, it's $31. So since April, Blue Cross Blue Shield of Tennessee has processed almost 52 million claims across Tennessee providers. Of those, only 1% are represented by falling within this particular E&M review that I've described a moment ago. We have adjusted 552,000 claims out of that 52 almost million claims. And that represents, on the right side, 14% of our entire provider network met the outlier criteria initially to be included in the review. And of those providers, only 7% of the total E&M claims that we received were adjusted. And that represented 13% of specifically level 4 and 5, which are the only ones that are the subject of this review. Of all those 552,000 adjustments, we've received appeals on 5% of those claims. We've taken some providers out, and no provider has appealed 100% of their downcoding, which, when we look at the records, is making us question whether some of it is appropriate and some of it wasn't appropriate, and we've reversed it. But in no case do we stop payment of the claim. All we're doing is reducing at the one level. So this is the edit that I think you're going to hear a lot more about from our colleagues that are in the Tennessee Medical Association. In closing, if you remember 3 things that I've discussed with you this morning, it would be these: that we're seeing a massive increase in claims expense, and our employers and our members are looking to us to find ways to try to control their healthcare spending. We do not use any artificial intelligence to deny or adjust claims anywhere at Blue Cross Blue Shield of Tennessee, and we are looking specifically for accurate and fair reimbursement with our providers, and only focusing on those that appear to be outliers from the E&M distribution that I discussed, where a high proportion of their claims are shifted to the most intense possible claims they could file. We adjusted only 7% of all the E&M codes that we've received, and we're actively looking for providers that are changing their practices, no longer an outlier, to remove them from the edit. That's all of my presentation this morning, and we're happy to answer any questions that you may have.
Well, thank you. We have a few questions. Representative Parkinson, you're recognized.
Thank you, Mr. Chair. Thank you for your testimony. Appreciate it. This is some Good stuff to learn. Got a few questions, just three. When these claims are submitted to Blue Cross Blue Shield, are the doctors not signing off on these claims, saying that these are true and accurate?
So the doctors do sign off, but in some cases, the doctors themselves file the levels. In other cases, they employ billing companies, and the billing companies do it on their behalf. So it would be a coder that would be submitting the claim, which the doctor may not actually see before it's submitted. So they handle the documentation, what's in the medical record, but they don't always manage the claim submission.
Okay, thank you. And can I continue, Mr. Chair?
Please go
Got a
ahead.
couple more. Thank you. What are the total, how many total outliers are there that fall into this group to be either reviewed or evaluated? What's the total amount?
So the 14% represents somewhere close to 4,000 providers
Okay, 4,000 providers.
out of 39,000 in our network.
4,000 providers. That's a lot of providers that fall into the outlier group. How are those outliers being reviewed or evaluated? Who's doing the reviewing and evaluating? That's what I want to know.
So initially, for them to be in the cohort that gets reviewed, they've submitted 50% or more of their claims to us as the highest intensity. Once they are in the actual cohort that's reviewed, our vendor Cotiviti does the first line review with one of their clinicians, and they look at the diagnosis on the claim with the level that was billed. And then on appeal, we look at the medical records with a clinician again against the level and the diagnosis.
Is it Clotivity or Cotiviti?
Cotiviti, CO.
Is Cotiviti utilizing AI to do the evaluation or the reviews?
No, sir.
It's not non-electronic?
Not at all.
Okay.
It's a crosswalk algorithm they have. So the easiest way to think of it is they have a big spreadsheet that basically says this diagnosis and what typically out of a bunch of data they have, they would expect the level would be for that.
Okay. And last questions is this. With that group of outliers, once the I forgot the term you used, but step down, or what's the term you use for?
Yeah, adjustment.
Adjustment. Once the adjustment is made, how much in savings is generated from that adjustment that may be made from that group?
So I don't have a total number off the top of my head. We can certainly follow up, but it's an average of $31 a claim.
And okay, then let me do this then. If it's an average of $31 a claim, how many claims with those 4,000 outliers?
552,000 claims.
So 552,000 claims times an average of $31 a claim.
Yes, sir.
Right. Okay. So that's.
So keep in mind, like in our Medicaid product, it would be a lower difference because of the rate. In the commercial, it would have the highest because that's paid over a Medicare rate. So
Okay.
it's Medicare is the highest reimbursed, or excuse me, commercial. Medicare sets their rates in the middle. And that's what we anchor off of is where Medicare is. We pay higher for commercial and a little bit lower for Medicaid.
Okay. So and just so I'm clear, I really want that number, 550,000
Times 31.
times 31. I wish we had a mathematician that could just tell me what that answer is.
Yeah.
1,500. 15 million.
Yeah.
15 million. Okay, so savings, it generates a savings of $15 million or money that would have been spent or
In a
is
claims
not,
expense.
right, that is
Yeah.
not, okay, dispersed. And how much, and that's annually?
No, that was between April 15th and December 31st.
Oh, so 6 months. or
Yes.
So, okay, and so in 6 months, okay, so $15 million in 6 months. How much profit did Blue Cross Blue Shield make in that year?
So our most recent profit margin was less than 2%.
What's the number though?
I would have to follow back up with you on that, but on a 5-year average, it's been less than 2%.
But you don't have you don't know what that 2% is?
I don't know the number off the top of my head.
Okay, all right, okay, thank you, Mr. Chair.
Chairman Martin, you recognize.
Thank you, Chairman. Thank you, Doc. And and Russell for this presentation. I just had one question in regards to the human provider review. Is that specific for specialty, or is that a nurse that oversees those reviews, or how's that work for you guys?
On the first level, it's typically a nurse. On the appeal, it's a nurse and a physician. And we do not always specialty match, but all of our medical directors are well-versed in the claims management of different types of specialties. So it's not a medical necessity review. It's really a appropriateness of the level review, if that makes sense.
And then as far as the outlier component, how long does it take to remove those individuals that are continued repeat offenders?
I would say on average about 6 months for changing practices. If they were an outlier and let's say they had a weird specialty niche that was justified in billing that intensity that often, they come off quicker. So a matter of a month or two.
You're okay. All right. Well, thank you. Did you mention that you've used some pilots in the very beginning of the process?
We did in this particular edit, we did some pilots, but the vendor's been doing this since 2006 and has been doing it in multiple other geographies and was doing their same edit with other payers in Tennessee. So we went with their recommendation and we started small and slow, but we didn't pilot a particular group of providers, if that's what you're asking, sir.
Yeah. Well, explain that a little bit better in the sense that give us an example of a particular pilot you conducted.
That's what I'm saying, sir, is we went with the vendor's recommendation because they've been doing this for a long period of time. And they've been doing it in Tennessee. So they had, and they made the recommendation to us about that 50%. And so, for example, we looked at behavioral health providers and determined that that wasn't an appropriate number. So we changed our approach and took behavioral health providers out. I realize I'm not answering your question, but there was no actual pilot for this. It was the vendor who had done it over multiple years, and we were taking their guidance on where to start.
Oh, I think you're telling me it's complicated, and which it is. So you do have some algorithms that you follow in claims processing.
Yes.
Okay. And are those algorithms automated?
No. It's all, for this particular edit, it's all after a clinician review. So Cotiviti would have a nurse review every single one of them before any decision was made. There's no automation in that.
And parallel to that, are those algorithms being analyzed by an automated process while the nurse is reviewing them?
I don't know the answer to that from an inter-rater reliability standpoint. I assume you're asking. I'd have to check with the vendor on how they manage their.
I'm just trying to differentiate between automated algorithms and AI. You know, where is the line that it becomes different?
Oh, I see. Yes, sir. So this edit is the same edit that they have launched in 2006. They use no AI with it. The only thing that is the algorithm is that crosswalk I described between a diagnosis and a level. So they have not changed their approach and used any kind of machine learning model to try to do that more intensely. They manually look at the data and then they make decisions based on, this is the vendor I'm speaking of.
Last question. Being a physician, I can't walk away from what may be medical. You showed a slide where after postpartum hemorrhage, the transfusions went up, but the costs went down. Is that?
Oh, no, sir. The diagnosis increased and the rate of transfusions decreased.
Decreased. Okay. Can you explain why?
Yes. I think the diagnosis of acute post-hemorrhagic anemia has some vague components.
Okay.
And artificial intelligence is able to latch on to some of those criteria that are less well-defined. So, for example, and I'm just saying this for you, a 2-gram drop in hemoglobin would be one example. So most women are going to meet that criteria, but that doesn't mean that they have acute post-hemorrhagic anemia versus just anemia of pregnancy and childbirth.
Well, thank you. Thank you for explaining that. Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. Mr. Marty and Dr. Sobel.
Yes,
Thank
sir.
you. When I use the numbers, I think it was like 1, 2, 3, or 4, something like that. With a lower level of service. I don't know if we're looking at AI or some other, I guess, algorithm, but has there been an increase in deaths because they receive services? I'm going to say they receive services at a lower level.
I don't know the exact answer to that question, but I can tell you that in our Medicaid division, our Medicare division, and our Marketplace product, we look at diagnoses and disease burden at an individual level, and there has been no change when you account for what they call risk adjustment, how sick an individual is in those populations. So to say that differently, people aren't any sicker that would warrant higher E&Ms, more intense E&Ms during the time period. But I don't know the answer on deaths.
Okay. If a lady has cancer, and would the process we're talking about, would that be more of a targeted treatment or a spray or an array of services that will be provided? I guess, are we targeting it, or are we just shooting everything at them?
So it's not denying any services, to be clear. It's simply the office visit component. And when you have someone who has cancer, they have office visits, and then they have procedures that are associated with their cancer, whether it's surgery, chemotherapy, radiation therapy. None of those services are in scope for this. It's just the office visit component and what was documented in that office visit record.
Okay, one last one, Mr. Chairman. The outlier providers. I don't know if we should think of them as less than, I'm going to say, the regular providers. I think they accept less money. I didn't know if that was some kind of implication that they're maybe more moral than somebody else, or what does it imply?
I think, again, it goes back to the electronic medical record software and the fact that it over-documents based on what the patient is actually coming in for a complaint about. And that's what the system then uses to justify it. I do not think providers are sitting and thinking about, do I code this as a level 3 or a level 4 or a level 5? It's the software that's enabling it. So the culprit to me in this is the AI embedded in the electronic medical record software, trying to get it more accurate and descriptive coding, which is a good thing, but at the same time missing the contextual application of information, meaning, does that diagnosis or that word group actually matter for a diagnosis? Because AI is so new, it needs to develop more. But we're seeing this phenomenon in the last 3 to 4 years, and AI has just really come on the scene strong at the end of 2022. So it aligns with early AI use, but I think what it's trying to get at is the right thing, which is accurately and more appropriately coding information from patient encounters.
All right. Thank you, Mr. Chairman. Thank you, Jim.
Yes, sir.
Well, thank you. We'll go to Representative Love. You're recognized.
Thank you, Mr. Chairman. Thank you for your presentation. And you're talking about documentation and coding. Just help me out with this a little bit. Are there services that may not have a code with them that directly connects to the service provided, right, when the doctor goes in? Does that make sense what I'm asking?
It does, and I don't want to overcomplicate with my answer, so bear with me, and if it's not clear, just tell me and I'll try to clarify. E&M, the Evaluation and Management Code Set, is these 5 codes for office visits. They have 5 codes for new patients and then 5 codes for established patients. And in that grouping, it's any outpatient office service. There are other codes that can be billed from an office setting, but if you just focus on that encounter, It's either based on the amount of time they've spent with the patient or the complexity of medical decision-making. So if I come in and I say, well, I'm 65 and I'm having chest pain, that is much more complicated for the doctor to manage because of the risk of cardiac issues than I'm a 20-year-old that comes in and says I'm having chest pain and don't have a history of drug use or anything else that could do it in that early an age. So it's one of those two things, time or complexity, that drive it. But any office encounter can be coded with one of those 5 codes. As I said, there's a variety of other caveat codes that can be added. I don't want to get into that because I know that would truly confuse, but does that answer what you were asking? Or
It does, and if you don't mind, could you go into some of those just so we get an understanding of?
Absolutely. So there are certain types of preventive service counseling. So if you're a smoker, for example, and I spend 15 minutes talking to you about why you should quit smoking, there are special codes that you can add. You bill that evaluation and management code plus that counseling code. And that's a whole preventive service code grouping. That's just one example. You could go in and have a annual wellness exam or a physical with your doctor. And when you're in there, you can say, hey, doc, I meant to tell you my shoulder hurts. Well, now that's problem focused because of the shoulder pain plus the physical that you went there originally for. So those are just a couple examples, not exhaustive,
Sure.
but that's how it would be additive.
That does help, and thank you for that. So is the problem that there are instances where the software detects that there's an extremely high number of codes coming in for patient billing, and then you have to go in and evaluate whether you think that actually happened? Is that where the problem is?
Yes and no. So at the end of the day, a coder should be accepting these diagnoses, or the physician if they're billing directly themselves. So a human is looking at it, but the system will suggest things. The coder wasn't there for the patient visit, so they're more likely to just accept what the system recommends. And that then increases the number of diagnoses, which then increases the intensity, which then drives up that claim filing.
Go ahead.
And so then if a doctor does actually do those several things and has those coded, but in your evaluation, you determine that maybe they didn't, is that where the disconnect is with the billing and payment? Because they know that they have done those things and they coded them to the best of their ability, and yet now there's a follow-up saying that we don't think that this happened.
It's not that it happened, it's that with the
Over and paid for,
diagnosis they filed, it's not likely that you would see that level of intense E&M visit for that diagnosis. So it's just based on the information in a claim, which does not contain all the medical record information. But if you changed it where the front end would be, well, we want to submit records on all of these and you can review those and we'll prove it, that's incredibly burdensome for the providers to submit all those records. And we don't currently have enough people that could go through those. We want to try to get through what we think is the highest degree of outliers. And again, pay for the things that are appropriate, which is why it's such a small percent of the claims that get touched.
Sure.
All right, go ahead.
Last one, Mr. Chairman. So I think one of the challenges we have is that for maybe some segments of population, the doctor's visit becomes the opportunity to really have those questions asked and answered about lifestyle or what led to this. I just had a doctor's visit on Sunday. Been dealing with back pain for 10 days, but just kept putting it off, and got the diagnosis of sciatica, right? If I said that right, I think that's what I got.
Yes.
But in the conversation, it was more of, all right, are you stretching? Are you stressed out? I said, no, in the legislature, we're not stressed out down there at all. But had those conversations, right, about what all is going possibly into this, how you sleeping, right? And so I think for some people in that moment, that may be the chance where they do have all those questions asked, and it may not seem like they match together, but they do, because that's when the evaluation comes together of what is going on that may be, causing all this.
So in your example, Representative Love, if you filed a diagnosis of sciatica versus a diagnosis of unspecified low back pain, it's the unspecified low back pain that would flag,
I
not
see.
the sciatica.
Gotcha. Okay.
Because then it's unclear as to what was really diagnosed or what the cause is. And that then becomes a mismatch.
Gotcha. That makes sense. Thank you, Mr. Chairman. Thank you for explaining that.
Yes, sir.
Well, thank you. In defense of AI, is it possible to say it may be better in incorrect billing or fraud detection?
So I think there'll be many use cases for AI agents in the future. I think the problem with healthcare is everyone's very sensitive around how the AI handles PHI, protected health information, and how it uses contextual applications, because the interaction between a doctor and their patient is very personal, very intimate. And because of that, it's very hard for the AI who looks for objective black and white information to find the nuances that the doctor was able to identify. So when it starts getting more into the gray areas, I think it will provide a lot of use cases. But this is more a situation of waste. It's not fraud, because nobody's doing this with ill intent. It's the software that's propagating this documentation. But if you go back to the American Medical Association when they created this, level 3 was supposed to be what most of those visits were. And it's clearly showing a shift now, and something's doing it. And it's not the providers getting out of bed every morning doing it. It's the technology that helps them with documenting all their encounters with their patients.
Does the electronic medical record have something to do with it?
Yes.
Okay, picking up diagnoses that may not be, don't change management and are not of any use, but they add to the numbers.
Yes, let me give you an example and then I'll explain it to everyone. So in the review of systems, if I come with a focused problem and you have a review of every single body system, how likely is the provider to have done that full review of systems versus the problem-focused one? Well, the EMR will force the over-documentation of review of systems, which goes to medical complexity. For everybody, the review of systems is the part of the medical record where they ask you a bunch of questions, like if you had a fever, it's how long, do you have cough? So it's every body system and all the components of yes, no questions that go with it. And usually in a problem-focused visit, it's focused on the review just of the system. Like in the back pain example, it would be about musculoskeletal, history of trauma, falls, anything like that, fevers. In this case, the EMR is definitely over-documenting the review of systems, which pushes up the complexity of the visit.
The idea was for EMR to be very thorough. Then there's a borderline between over-documenting. Chairman Spicky, you recognize.
Thank you, Mr. Chairman, and thank you for coming to testify.
Yes, sir.
The thing that's perplexing to me, as I've sat here for 8 years, every year we seem to remove more and more of the human component to healthcare. We become more and more mechanical. What do I have to ask you to, so I can do the code, so I can get paid, so my claim might get declined, so I can go back in and contest it. And it's this endless cycle of, we've taken the human compassion component out of healthcare because it's being mechanized by codes, by, well, if I use this code, am I going to get paid on it? Even though I know I may not get paid on it, am I going to be able to provide the care to the end user? Healthcare has become extremely mechanized. It has. Let's face it. It's driven by the almighty dollar. It is. The last time I checked, Blue Cross Blue Shield is not filing for bankruptcy. They're not. Okay. Multi-billion, probably could be multi-trillion dollar corporation. And they're a corporation. I get it. they're probably vertically integrated where they have the insurance company, they have PBMs, they have pharmacies, they have providers. It's business. I get it. The first thing I'd like to ask you is we said a lot over TennCare. I'd like you to break out all your slides that you have on how you're using AI and stuff and all these claims adjustments and how many claims. I would just like to see that reflection as TennCare. What we have direct oversight over. What does that look like to us? Is it the same numbers? Is it the same percentages? Or is it different anomalies? Are we coming down harder on TennCare of those people who are the most at risk to health anomalies? So that's the first thing I'd like to request. And if you get it to Chairman Kumar, he could disseminate to us. I think that's very important to us. Go ahead. Oh, I'm
I
sorry.
was going to say we will do that. We are planning a presentation by the 10K MCOs,
Wonderful.
and that'll be a very important question for them. And I think you'll get another chance at it.
I'm sure that'll be a very thorough discussion by this committee too,
Yeah.
Mr. Chairman. Okay, so yes, you do not use AI to deny claims. I agree with you there. But I have family members who were the people who used to look at claims, all of them. And they had this predistribution of, I'm just looking at the claim, making sure the diagnosis and the claims and the codes match up and make the payment. They were not under the auspice of they are now, of the only claims I'm seeing are the ones that AI has flagged for discrepancy. You've changed the way people are looking at claims now, the human element. Instead of just, hey, my job is to look at these 500 claims that come in and just evaluate them based on what I see, now I'm being given 10 claims that AI has flagged for anomalies. The human element there has now put a predisposition in that there's something that AI doesn't like about these claims. So you're not using AI to deny the claims, but you've changed the way people are looking at claims. The human element has now changed because now they're looking at something that AI has flagged for a discrepancy, which automatically the human element kicks in there and says, there must be something wrong here. I'm going to look to deny this claim. I think we need to look at that. I think the reason why you're seeing more claims is because the providers are using AI because they're trying to get everything coded correctly. And we got people sitting on this committee that know this a lot better than I do about the codes and stuff, but I think I know it just enough to be dangerous to say this doesn't start making sense here. So first of all, I would love to see the numbers that you provided with TennCare. Number two, I know you're vertically integrated, so on this part of it, you have I assume you have a PBM that you manage?
You recognize.
Thank you, Chairman Sapecki. We are not vertically integrated. We are a single state, not-for-profit blue plan. We do not own a PBM. We do not own provider groups. We do the business of insurance.
So Blue Cross Blue Shield doesn't own a PBM,
That's correct.
No.
doesn't own any providers,
That's correct.
No.
negotiates no contract with PBMs or pharmacies.
We contract with the PBM to manage our pharmacy benefit. We do not have an ownership or stake in a PBM though.
Does Blue Cross Blue Shield negotiate the contract with the PBM?
We enter into a contract arrangement with the PBM. Yes.
So that'll be another discussion for when the MCO comes in. So how do we put the human back into healthcare at the provider level? When the providers are driven by nothing but data and analytics and actuaries, the conversation, and I know I'm droning on here, I apologize. The conversation when I was younger, a lot younger, going to the doctor, and I'll tell you his name, is Dr. Hugh Mestris. I still remember his name. It wasn't a checklist of how do you feel? He was like, he just have a conversation with you. Why are you here to see me today? And develop that rapport that the doctor knew who you were instead of your patient number. And it seems like from the insurance claims all the way down to providers, everybody's trying to figure out how to manage the system so everybody can get paid. is there a way to put the human element back into healthcare so we can help people instead of looking at how much we're going to get paid? That's a question. I was curious. That's my last question.
Well, no, thank you. You make a very important point in the sense that there's been a seismic shift in healthcare, so that our healthcare providers are mainly corporate entities.
Yes.
I don't go to my doctor's office. I go to a corporation. I'm not his patient. I'm a patient of St. Thomas or Vanderbilt or some entity, because all physicians are working for them. Reason that shift happened was the Affordable Care Act that would pay. The famous example is of a patient going to see his physician, let's say a cardiologist, getting a physical examination, EKG, and an echocardiogram, right? He paid something like, at that time, the charge was about $350. He goes back 3 months later for a follow-up visit and gets to the same building, same doctor, same technician, same machine, same bed, gurney that he lies on, and it does the same tests, right? Next time it's $1,500. The reason being the doctor has sold his practice to this particular entity, and the corporate entity is able to negotiate better contracts. So out of the $1,500 that the corporate entity gets, the doctor gets a raise from, instead of $350, they get $700. The corporate entity is making $800 more. And therefore, doctors don't really go to practice themselves. They don't have the responsibility to the patient. Dr. Marcus Welby is no more, right? Okay. In the interest of time, Representative Parkinson, it's your round 2, but we need some time for the next presenters also.
Yeah, and I'll end it there. I appreciate the discussion. You know, this has been enlightening to me, and I'm sure to some of my other colleagues as well. You know, some y'all answered some of the questions with some of my other guys, and especially in regard to, I was concerned that this could lead to some criminal investigative situation with some. Okay, and that was answered. So I appreciate you. Thank you so much.
Thank you.
Well, I think all hearts and minds are almost clear. Thank you very much, Dr. Sober, for a very good presentation. And Mr. Marty, thank you.
Thank you, Mr. Chairman.
We'll go on to our next presenters from the TMA, Ms. Julie Griffin and is it Dr. or Ms. Meredith May? For the record, kindly introduce yourself and tell us what you think of all this. No, thank you.
Is it on? Okay. Hi, I'm Julie Griffin. I'm with the Tennessee Medical Association.
And I'm Meredith May, Revenue Cycle Manager for Murfreesboro Medical Clinic.
Mr. Chairman, members of the committee, I want to thank you all for giving us the opportunity to speak today. I'm going to be brief and let the majority of our time, let Ms. May discuss her experiences as a medical practice. Anyway, claims processing has become a nightmare for medical practices. Insurance companies are systematically downcoding claims. What does that mean? I think you all heard it's receiving a lower amount of money for a claim that you billed at a higher level of service. Payers will tell you that the providers are upcoding or they're using AI to basically pad their reimbursements. I would bear to differ with and talk about what you said. They're trying to make sure that they're using AI to accurately reflect in the medical record what transpired in the patient-physician encounter. That is what they're using AI for, not to upcode, not to pad their books. They are doing it because they want to make sure it's an accurate reflection of what happened. These new payment processing programs are costing medical practices in both misprocessed and delayed claims. This is happening all over the state of Tennessee, in both rural and urban communities alike. For instance, one medical practice in West Tennessee, having less than a handful of medical providers, had more than 800 claims downcoded. Of those almost 900 claims, only 11 were denied in the physician's practice's favor when they appealed. Over 300 had been overturned, and the other 400 that were still in process. But to appeal these decisions, it's as expensive as well. One solo practice in East Tennessee had more than 350 downcoded claims, and they had an overturn rate of 96%. That practice spent about 20 minutes per appeal, equaling about 116 hours of manpower lost fighting for payments that they had earned. But don't take my word for it. I've got a practice manager here that I want you to hear from Murfreesboro, who will tell you exactly what their experience has been.
Mayor, thank you all for your time today. The downcoding of claims has had a significant impact on our practice. Since April of last year, there has been approximately 4,000 downcoded claims that have affected our practice. I've had to hire 2 additional staff members to solely manage these downcoded claims. We are in the process of reconsidering them. For the ones that we have received that reconsideration, which is time consuming, approximately 20 to 30 minutes per reconsideration, there's been a 97% overturn rate in our favor, which supports our coding is accurate. We do utilize a tool in our medical record that strictly reviews the documentation that has been notated by the physicians. It does not suggest diagnoses, and there is a professional coder who assigns the diagnosis and the appropriate level code for 100% of our claims that are submitted. I also have examples of claims for patients with breast cancer diagnoses that are downcoded. So that's just unreasonable. This has led to increased statement cost because when these claims are overturned, we're then billing the patients again. We've already billed them once for the original processing. Then we have to bill them the difference after, which also has increased our call volume as an explanation to our patients on why they're being billed additionally. So this has been a significant impact on our practice.
Do you have any questions? Representative Hakeem, you're recognized.
Thank you, Mr. Chairman. Thank you, ladies. Clarity on the last item you spoke of about someone with cancer. That down coding, does that mean less going forward, less care that you provide to that person? I guess, are they making mandatory what services you provide to that person? I don't know if I'm making it clear.
No, there's no impact to the treatment that the patients receive in these situations.
Okay. All right. Thank you.
Yeah. Representative Parkinson.
Thank you for your testimony. So you're rendering the service and then submitting the claim, and then when it's down coded, the service is already being rendered, but you're not being paid for it.
Correct.
Okay, thank you.
Chairman Terry, you're recognized.
All right. Thank you, Chairman. My apologies for stepping in and out. And so this question that I have is a little bit off a little bit, but going back to the previous presentation dealing with sepsis, and it showed the having that up there and 7% increase, but the days going down. Would you agree that sepsis is usually an in-hospital claim, correct?
Correct.
Okay, and so, what we've seen in medicine over time, and I think there's a bit of confusion on here, is that in the hospital, these providers are employed by the hospitals for the most part. It's going more and more that way. And so there was some discussion about potentially the doctors are doing the coding, but that's not necessarily the case. It's the hospitals are the ones doing the billing, correct? If they're employed.
I would say that the hospitals may do the billing, but the providers sign off on every claim that they're accurate.
So, the why is I guess the question is why is the code potentially going up and why we're getting sepsis more versus going down? And to that, in my observation, obviously we have a physician shortage. The AMA is saying we're looking at 124,000 physician shortage. And so what you're seeing more and more in hospitals, at least what I've observed, you're seeing a lot more mid-levels that are in there taking care of the patients. And so when a patient comes in, I think it's important for everybody to understand this. When a patient comes into the hospital, oftentimes as physicians, what we are trained to do is develop what's called a differential diagnosis. And so the more training that you have, and of course, AI may just give you a big, long list of what's out there, but the more training that you have, you can narrow down that differential diagnosis. But if you have, more mid-levels, or if you don't have enough physicians out there that are, you have more patients and less physicians at some point, and whether it's the mid-levels or more patients and less physicians, you have a broadened differential diagnosis, which drives up the cost because you're going to have sepsis on there because they have certain vital signs. And so you have to rule that out. And so that's why that's probably in there. So I think that would explain potentially why you have a higher incidence of sepsis in the differential, and the hospital days drop once that narrows down with the test. So you have the increased number of tests because of the shortage. Would you agree?
Absolutely.
Thank you.
Chairman Spicky, you're recognized. Pass. All right. Anybody else have any AI-generated questions? Chairman Sparks?
Ma'am, what was your name again?
It's Meredith May.
Yeah, Meredith. My wife goes to visit Charles Clinic, and they check her for breast cancer. So you hit home when you talked about that with me. So this isn't AI generated, Chairman. No AI here. What I have seen with healthcare, and I'm not an expert like Chairman Terry or Kumar or Bob Freeman on healthcare, but we do worry about healthcare. I mean, look at the TennCare budget, how it's increased, cost, how it affects families, bankruptcies. Fortunately, we got good insurance up here. A few years ago, and maybe Julie can chime in on this, I had a bill on reference-based pricing, and had a guy come up, Ralph Weber, wrote the book, Rigged, How Insurance Ruined Healthcare, Rigged. It's available in my office. I've got about 20 copies if anyone wants to come by and get it rigged. Anyways, when he started looking at some of these outliers, he probably had AI before we had AI. And he said, man, you got so many outliers with cost. This is ridiculous with your state plan. He says, if you'd have been outside the plan, you'd have saved $92 million to taxpayers. We were in a TASER study, had it before Chairman Hilton's committee. It didn't seem like I can get lawmakers to pay attention. The media certainly isn't paying attention. They're always silent the wheel. This is controversial. But this is a serious issue. Just like when my wife visits y'all once a month. It's serious. Now these, I'm going to disagree with this chairman for a little bit. I mean, use AI if you can, where it's going to be more efficient, because people can't afford to keep this going. I mentioned the $38 trillion worth of national debt that this country is facing that we're leaving to these kids in this audience right here. So, Chairman, I'm not an expert like some of y'all are, but every week we need to have this discussion. Every week. This ain't a Democrat or Republican issue, but the system, I hate to say it's broken. It's broken. Like Chairman Terry talks about the lack of doctors. But I appreciate you coming up here and testifying. But I like what this guy told me. He said, Mike, you got to remember, all due respect to Blue Cross Blue Shield, he goes, you know how powerful these people are? You know how powerful they are? He says, they could buy Tennessee and sell it to Russia. And I just thought, wow, that's powerful if you could do that. That was his quote. Ralph Weber, I'm sure he'd fly up here from Houston, healthcare expert. If you want to know more about Ralph Weber, pull up MetaBid. on YouTube. He's got a podcast, brilliant guy, but thank you for your testimony, ma'am.
Representative Love, you're recognized, sir.
Thank you, Mr. Chairman. And I want to follow up on, hello? All right, thank you. I didn't see the red, so thank you. Chairman Terry raised a point. I want to follow up on this. Are there instances, I think, where the coding that happens in the hospital is not under as much scrutiny as it is in the doctor's office, or is it the reverse? Do you find that any data on that in the hospital there's less review, or is it more review in that instance?
We are not experiencing down coding for any services provided in the hospital. It's the outpatient only.
Okay, it's interesting. Thank you.
Wonder if you know, is upcoding a problem in medical billing by the provider?
In some areas, it may be if
Um,
physicians are assigning codes, but that is not the case for our practice or for
Okay.
others that I know.
Yes, Ms. Griffin.
If that is a problem, I think that there's a process by which to deal with that provider. It's a fraudulent claim. And there are things in the contract that stipulate how a fraudulent provider is going to be dealt with. This is strictly a way to not pay for the level of service of which the provider believes they should be compensated based on what took place in that patient-physician encounter. And these are small businesses. I mean, these medical practices are small businesses. So any delay in their reimbursement based on what they provided to those patients is affecting their bottom line and their ability to continue to take care of patients, particularly some of the lower reimbursed patients like TennCare patients and things like that. You know, it's really important that providers that are doing it correctly be paid promptly and correctly. And if they're not doing it correctly, there is a process by which to deal with those providers.
You're right. It also takes attention away from patient care, which is our main responsibility. Chairman Lafferty, you recognize?
Thank you, Dr. Kumar. I'm going to preface this question with a conversation I had with a pediatrician years ago. I won't get too deep in the weeds, but essentially she told me that if she could cut out the insurance companies altogether, she could let go a couple of people in her front office because she wouldn't have to be doing the back and forth with the claims. She could spend more time with her patients, and she could probably charge a flat rate and get more time with her patients in doing so. And as a bonus, she even thought she might make a little bit more money. Well, yeah, let's, heaven forbid, that should happen. But I use that example to preface the question. Has anybody looked, and I don't know if this is useful for this conversation, but has anybody ever looked at the cost of, and this may have been a question for the others, has anybody ever looked at the cost of doing all this back and forth over claims fights and adjustments and everything else versus what the actual fraud level might be? And is there a correlation there? If we're doing the back and forth all the time, we know that we're adding cost by every time you pick up the phone, every time you go to the computer, somebody's time, somebody's energy is taken to have that back and forth continually versus, you know, we've probably got what, 10%, 7% in legit fraud out there? Are we over, are we paying more to fight claims than we are to just pay the fraudsters and maybe hopefully catch them down the road and put them in jail? Has anybody looked at it? I'm sorry, last part of the question.
I think that's a question for the payers. I will tell you that you're not the first person to tell me, first to hear of a provider say that dealing with the insurers costs them more money than need be to take care of the patients. I will say that system, the system by which we used to live, where you had the insurance company that wasn't in between the doctor and the patient, before we started having the claims billing, and the insurers would pay a percentage of the claims, and it's put the providers in the middle between the patients and the insurance companies. And the providers are just trying to make sure that they take care of the patients and at the same time run their business. And that process has gotten overwhelming to providers. And it's prior authorizations. It is everything that is happening to providers to keep them from getting paid for the services that they render and the services they believe that patients need.
Thank you for that. Thank you, Mr. Chairman.
I wonder if Dr. Sobel would have an opinion about it. Would you come and join the party here and add your perspective? I thought from a peer's point of view, you would have input. Thank you.
Thank you. So I too have heard providers make that type of a statement. And I do agree that there is some level of administrative burden. But if you look at what's happening in healthcare today, there are gene therapies like sickle cell therapies that are $2 million. So if you take insurance out of that and a risk pool out of that, how is that pediatric patient going to be able to afford that type of therapy? It's not just about the providers, it's about all of the stakeholders that are involved in the healthcare ecosystem, in my opinion. You've got the providers, you've got the labs, you've got the medical technology companies, you've got pharmaceuticals, and all of that is creating a process that technology comes at a cost. And from an insurer standpoint, again, the Affordable Care Act limits what we can make in profit as an insurer. And it has since it went into enactment. Focused on trying to provide the services that our employer groups want and our individual members want. And they all want to be able to afford health care. And so we're not targeting a particular provider. We're not trying to put the smaller providers out of business. But the information I shared on the graph is real. That's a Tennessee provider group also. So when we're talking about a provider group in West Tennessee, I don't doubt that, but I also see what I shared with you happening. So we're trying to pay the right thing for the right service that was provided.
Thank you. Members, we have 3 members that want a turn, and we have 10 minutes. So please take 3 1/4 minutes. Chairman Spicky.
I'll pass then.
All right. Well, thank you. Representative Freeman, you're recognized.
I'll take the chairmanship.
Okay.
Thank you, Mr. Chairman. The question I've got is, we're talking a lot about diagnosis and then treatment. Who sets the treatment protocol for diagnosis? Is it the insurance company, or is it doctors and medical schools and the history of medicine?
I would say that the doctors should set the treatment, but a lot of instances, it's the insurance companies that are deciding what they'll pay for.
Yeah. And sir, to your point, the $2 million sickle cell treatment, Representative Sparks, Chairman Sparks and I have had this conversation multiple times. We had a breast cancer scare in our family, and the number of hurdles that my wife's doctor had to go through to get the treatment that she knew was the right treatment, that the insurance companies wouldn't provide the treatment because of the expense. And I guess I appreciate your concept of, if you're not there, how does that ever get paid? Well, if the treatment doesn't happen, are these people here moving forward, right? I mean, the doctors have a responsibility to save lives. You have a responsibility to provide the payment for it. And I appreciate the dance between the two, because you can't spend all the money because then there's no money left to pay the doctors and vice versa. But at what point do you feel like it's gone too far? Because to the point made a second ago, I hear all the time from my doctor friends that they would have never guessed when they were in medical school 25 years ago that they would spend this much time dealing with insurance companies and the back end and the bureaucracy of what gets paid for what. And I mean, I feel like I hear from the doctors over and over again that we have gone too far. You're a doctor. Do you not believe that you know what's best for your patients? Or do you think that someone who is reviewing an AI flagged, conflict of a diagnosis versus a treatment protocol is more accurate than the person that actually saw the patient eye to eye and knew what they were doing and called in the tests? And I mean, explain your rationale there, because to me, it just doesn't make sense that someone in a back room, whether they're a doctor or not, has better insight into the treatment protocol for a patient that someone actually saw.
So the first thing I'll say is, just to clarify again, we're not using AI to flag anything. Nothing is flagged by AI. So we have clinical teams, physicians, pharmacists, nurses that do look at clinical information. And all of the policies that we use are based on evidence-based guidelines. So it's not that we're saying that we disagree with a treatment that a physician is prescribing. It's, for some reason, either the information they provided doesn't match the evidence-based criteria, or it doesn't match and they did provide all the information. And so what we're trying to do is follow the best guidance. So we use National Societies for Oncology for our criteria. These aren't arbitrary criteria that we develop. Everything, and you can go online, it's all publicly available, has literature with it. So I do realize that there are times that the prior authorization process creates burdens. We are trying to reduce the volume of services that we require prior auth, and we've done so already. We're doing more with that. And in fact, now we introduced a new system last year for radiology procedures like CAT scans and MRIs. And we're getting positive feedback from providers all over Tennessee because it flags for them what information's missing, rather than them wasting time going back and forth with a denial and then having to file a reconsideration. So I do respect it's not a perfect process, but there's an art to medicine and there's a science to medicine. So I think my response personally would be, patients don't fit one size, evidence-based guidelines don't fit one size, and trying to match the right patient for the right treatment is not always easy from a provider's perspective.
Thank you. Thank you. To wrap it up, Representative Parkinson?
Thank you, Mr. Chair. I found it interesting that these claims are, and anybody can answer this if you want to. These claims are being labeled as waste versus fraud when the doctors are signing off on them. So if I sign off on my campaign finance report, me as the state representative, it's not going to be viewed as waste. It's going to be viewed as fraud, right? And there's criminal attachments to fraud. And so if a doctor is with this patient and saying everything that they're doing and then remitting the claim, why is that? Why, when y'all create the outliers, is that being deemed labeled waste versus fraud? When, of course, based on what you guys are saying, and you're down, what do we call it again? Down coding, saying that no, this does not go with this, or this should not have happened. Tell me why you guys decided to label it waste versus fraud. The last thing I want to also, and y'all can answer both of these, because the claims are being reviewed, has there ever been a situation where you've upcoded any of the outliers for the claims that they've submitted to you all? And I'll leave that for you guys to answer. Thank you, Mr. Chair.
So for the first part of the question, there's no intent to commit some crime which is necessary for fraud. It's something that happens because the doctor believes that the criteria is met. And in some cases, it may be met, hence the overturns on appeals. But in other cases, it's not met. because it's still a very small portion of the total that are appealed. So we don't consider this something that people are doing with evil intent. We think it's a byproduct of the way the software is created for the electronic medical records. And doctors do attest to what they're submitting, but it's not a perfect diagnosis criteria system where this, and this has to be present to meet that diagnosis. And that diagnosis then feeds the intensity level of the services that are provided. So we're not disputing the diagnosis. We're disputing the intensity of services that were provided during the doctor-patient visit. And that's why we're calling it waste. And then on the second part of your question, I'm sorry, can you remind me of that last part?
Yes.
Upcoding it.
Yes.
So no, we don't do that. The provider files what they feel is appropriate. And if they filed a level 5, which is the highest, and we agree with it, it stays a level 5. If they file a level 4 and we look at it, we leave it at a level 4 if it meets criteria. Similarly, on the opposite side of that coin, if we on reconsideration review the record and feel it should have been a level 3 and they filed a level 5, our process still pays them for a level 4. And the key with this particular edit is the providers are getting paid timely. They're not getting the level that they billed, and that's the cash discrepancy. So I just want to emphasize, this is not a non-payment scenario. They are getting paid for the encounter.
But if you're reviewing for discrepancies, shouldn't that go up and down? And shouldn't, if you see that this doctor is, according to what the record is presenting based on their honest opinion of, or what the AI, whatever it delivers to y'all, shouldn't that go both ways?
It could go both ways, but my suspicion is the people who are not identified as outliers for this particular program are probably the ones that are most likely to deserve to be upcoded, because they're probably coding lower than their peers.
Okay.
So we don't see those because they're paid.
Well, thank you. Very logical. I'm sorry? Sure, but thank you for your logical question. That makes sense, doesn't it? Please go ahead.
Mr. Chair, thank you for the personal privilege. I want my intern to stand up. Ashley Figueroa, if you will, stand up. Y'all please make her feel welcome. She's awesome. Yep. I hope she's getting something from this. Thank you.
Thank you for a very interesting discussion. We'll go back into the session. Our remaining agenda is postponed or rolled to next week. And we stand adjourned.